This is a simulation which we are going to take you through for a COVID positive patient who unfortunately also appears to be having an anterior myocardial infarction. It'll finish with us arriving on the intensive care unit, handing over the patient to the ITU team.
Primary angioplasty, suspected COVID coming from LAS, going to the heart, ETA 10 minutes. Primary angioplasty, suspected COVID coming from LAS, going to the heart, ETA 10 minutes.
Hi, you're the interventional fellow?
Yes.
Hi, I'm the cardiology reg on call. I've just assessed this gentleman in the ambulance downstairs. This is Mr. Smith. He's a 58-year-old smoker. He's been self-isolating for the last week with a cough and a fever, so he's querying COVID. In the last hour, he's had chest pain radiating to his left arm, crushing in nature, and the ambulance ECG shows us the elevation anteriorly, as you can see there. He has no other past medical history. He's on no regular medications, and with the ambulance, he's had 300 milligrams of aspirin and got 5 milligrams of morphine.
Thank you. Mr. Smith, hi, it's one of the heart doctors here.
Yeah.
How's the pain? It's still 10 out of 10?
Yeah.
Well, looking at your ECG, I think you're having a heart attack. That means that one of the heart arteries is probably blocked. We need to do an angiogram to have a look at your heart arteries and try and unblock it for you and make you feel better. Can someone get me a consent form?
Welcome to this session for EuroPCR, where we will be discussing use of simulation to improve outcomes in the midst of us emerging from the COVID crisis. So we have several objectives that we want to share with you. We want to learn how to integrate simulation into the cath lab to use it as a tool that's going to be of benefit. We want to experience crisis management without exposing a patient to any risk, so that we can improve both quality and safety. We want to optimize the way the multidisciplinary team works, because it is a large team, especially when a crisis occurs. And finally, we want to develop new processes which can be tested without involving a patient at risk. So let me introduce Dr. Rasha Al-Lamee, who is a consultant cardiologist from London, UK, and also Dr. David Sparv, who is the chief nurse of a large hospital group in Sweden. I thank you both for joining us today. You are able to ask questions via the web tool that we will be able to see interactively and answer in that same bar. So here we go. The lateral mannequin, which has been developed by Mentis, can be placed onto a Siemens or a Philips cath lab table, and then the case is treated pretty much as a normal case. Let's imagine vascular access has been achieved, and then the whole case runs pretty much as normal thereafter, including defibrillation on the mannequin if required. So we've seen the start of the situation. What do you think that's going to add to the way we practice already?
What this really adds is due to the lessons, I would say, from the flight industry that has been good at training for many years. In order to be able to act what you do with your brain, or not react what you do with your emotions when you're under stress, you have to be able to train in a sort of like a daily basis environment. It's a great way to learn, even long before the COVID-19 pandemic. Even more so today, when we have new constellations of staff that have never worked together before. We have new situations and new both nursing and medical things that we have to consider in a cardiac arrest or in the primary PCI.
Okay, so Rasha, do you think there's a value in the pre-brief before doing a simulation?
For it to be useful, it really has to simulate what you do in real life. And for us in our cath lab, a pre-brief, overview of the case, discussing with the team what equipment we're going to use, discussing what everyone's roles are, is key to every cath lab procedure we do. So I think if you're going to do simulation and make it real, then you have to do what you would do in real life. I think what's most important about simulation, just to add to what David said, is that simulation also allows us to kind of make mistakes. What happens in simulation is when you make your mistakes, actually you see the real-time effects of those mistakes and you learn. You'll never make those mistakes again.
Simulation could be one of two things, couldn't it? We could actually deliberately put in some hurdles, or we could actually let the simulation run as we would ideally want it to. So we'll discover during this video whether it's absolutely ideal or not. So as we assess this patient on this video, he was labeled as COVID positive. So David, how does that affect the assessment that the team would do right at the start? You saw that our fellows were in full PPE. Is that what's done in Sweden?
We also use the full PPE if we have a suspected or confirmed COVID-19 positive patient. And I would also add that our paramedics, our ambulance system, they are extremely good at very swiftly catch up the potential COVID-19 patients. So we almost all the time get a very early alert that this could be sort of this patient, and then we put on the full PPE equipment.
Okay, so full PPE is on, and Rasha, you work in the same center as me, so that there are our fellows, so we of course are wearing full PPE. The issue of informed consent, so this patient not only would be having an infarct, maybe having some medication from the ambulance crew, but also may well be a little delirious from his COVID-19 disease. How do you handle consent in that process?
We have to, at the very outset, assess capacity to be able to make decisions and to be able to consent. And I think you could argue that in this setting, this patient may well not have full capacity. Here, it's very important that we do things that are right for the patient. The tricky thing that we have now in the COVID situation is that these patients are coming in without family. So there's no one else you can speak to. So what we've been doing is obviously we try and assess capacity. If it seems that capacity isn't there, then we do the procedure based on the best medical interest for that patient. If we've had time, we call a family member on the phone, just tell them what we're about to do so that they understand the risks of the procedure and understand that potentially their relative may not survive that procedure or may have complications during the procedure. I think it's always easier to have had that conversation ahead of time than to later be suddenly surprising the family with new information.
Rasha, do you feel an echocardiogram to assess LV function prior to a primary angioplasty in this era is worthwhile or not?
Our practice at Imperial, and I think in most centres throughout the UK, has been to do a very quick handheld echo before doing any cath lab procedure. It's very useful to know that if there's an LAD infarct, perhaps that the whole of the LAD territory looks thin and akinetic, and I may not have much to gain from my angioplasty. The tricky thing with the COVID crisis has been that we didn't really want our fellows and our team to get too close to those patients and expose themselves to risk. So we haven't been doing echoes on those patients. Sometimes I've really wished we had the echo during the procedure, but actually we've just had to get our mindset around the fact that we don't necessarily have all the information that we normally do.
The team is set, ready to go. Okay, so we're all full PPE?
Yeah.
Okay, so Aggie, you're our nurse, Callum, radiographer, Fatima, physiologist, Richard, the Iqbal doing it. Okay, only us two are sterile. Must remember that because we all look the same at the moment. Okay, yes. So his COVID status, we presume he's positive.
Positive.
Okay, so he's got a temperature, he's got a cough.
Yes.
Okay, fine. He's also having an anterior implant. Okay, any allergies?
No allergies.
Okay, any consent done?
Consent form is signed.
Fantastic, and bloods have gone off, we don't know the answer yet. Okay, so we are ready to proceed, the patient consents to the procedure. Okay, fine, that's good. So we've got access available already. Okay, so let's crack on. Okay, Fatima, the pads on.
Yeah, pads on.
Fantastic, okay. So we can see the screen, the initial observations, there's steady 92, 107, saturation is 93. Okay, so let's shoot the right, Richard. Let's take a next shot. Let's go to the next angle. Okay, that's good. Next angle. That's good. Okay, so we can see it. I think that's probably the best way to wire it, Richard. You can see the number bit. Inject. Oh dear. Okay, fine. That's it's a big LED that's included. Okay. I need a BMW wire. Okay, can you go PA cranial, please?
Yeah.
Thank you. And just get a tube balloon ready.
Okay, balloon. Yeah, balloon.
Okay, let's take a finger. Inject. My God, it's going to be he's in trouble, this guy. Okay, fine, fantastic. So let's just leave that wiring, get the BMW ready. Okay, are the pads definitely on? This guy's in trouble. Okay, fantastic. Okay, so let's watch that rhythm. Okay, good. Let's carry on with the wire.
Yeah, wires here, sir.
Oh, okay. So that looks like a VF. Okay, back him up. So it's VF. Okay, back him up. Can you shock this patient? Get the camera up. Get the camera up. Okay, shock. Oxygen away.
Shocking. Shock delivered.
Okay, still carry on. Another shock.
Okay, charging. Everybody clear?
Yeah.
Shocking.
Okay. It's still VF. Okay, shock again.
Okay,
Ready for
charging.
CPR. Yep, ready.
Everybody clear? Shocking.
Still VF. Okay, CPR please.
Oxygen
Okay,
back on.
oxygen back on.
Okay, so we've now seen that the case has started. As you can see, it looks fairly realistic as a cath lab environment. And then unfortunately, as sometimes does happen, there is an arrest. And we like VF arrest. They seem to be the most correctable. And this patient is in VF, and a CPR is beginning. In the UK, we've got a big debate about whether a CPR is an aerosol generating procedure.
Very early on, the Research Council took the view that this was an aerosol generating procedure and that everyone in the room should be in PPE before we considered performing CPR. And then, in fact, if you didn't have PPE available, they took a very hard stance that you probably shouldn't be performing CPR on these patients. The flip side to that is that Public Health England said that this wasn't an aerosol generating procedure, that basic protection was necessary but not full PPE. And I think as a result, people have had to take their own view. In our cath lab and in our ward settings, we have very much considered that CPR is an aerosol generating procedure, and we've gone to the highest level of risk and therefore the highest level of protection of our staff. So I would not expect anyone to get involved in CPR until they themselves were protected. And that's one of the primary reasons actually that for our primary angioplasty procedures, we headed towards full PPE at the very outset, knowing that for many of these patients, there is a possibility that they may need CPR.
Okay. And so where is Sweden at, David?
According to the Swedish Resus Council, National Council for CPR, and the Swedish Board of Health and Welfare, CPR could not be delayed. But we consider it an aerosol generating procedure. But still, even though we don't have protection on, we should start with compressions, but not ventilation. So that is the authorities' view in Sweden. But that has resulted in the cath lab that we always use PPE.
We generated a video very early on, which is available on YouTube, which has had nearly 100,000 views, which actually deliberately paused the resuscitation of a patient with COVID because we wanted to protect the first member of the team. And it's a very painful watch to actually stand there doing nothing. But the view that we took, and it's not an imperial view, it's not a UK view, it's a view that the cardiology team took and shared at Imperial, that the team was paramount, and that if a patient has had a cardiac arrest and is COVID positive, at least on the COVID ward, the outcomes are so poor that actually delaying the resuscitation is not a great, it's not a terrible thing. I think it's slightly different in the context of a STEMI coming through the door, but that's why we then tool the team up. London Ambulance says, just like your Swedish service is fantastic, they deliver the patient already with a suspicion of COVID, so we have time to do what our fellows did. We have goggles and a visor, probably both goggles and a visor to stop the splash, an FFP3 mask, a hood, at least one gown and one set of gloves, and if it was truly COVID positive, we're putting 2 gowns and 2 gloves on. Some of our videos have Wellington boots in as well, and I think, David, you shared the fact that you didn't do that, and I think we don't do that routinely anymore either. It's just that Emma, who was one of our cath lab radiographers, actually is from a farming family who was hit very hard by foot and mouth disease. And so the farmers took that line to minimize exposure. So we have these Wellington boots, which are available for resale whenever you want, David. Okay, there's a lot of them.
Okay, can we move the camera, please? That's it, you're doing well. Is the anaesthetic team called? Yes?
Yes, sir.
Okay, good. Let's wait for them to come. Okay, they're going to have to pull full PPE on. They need to put their legs on as well, okay?
Yeah.
Hey, Chloe, hi. Can you hear me?
Yes, I can hear you.
Okay, so we've got this patient who's got a temperature, a cough, and has had an anterior infarct. We've started, but we haven't finished, and he's arrested. We've had 3 shocks. We're doing CPR. So can you get your team in full PPE and come on in? I think he's going to need intubation. The rest of your team can get changed quickly.
Sure. We'll be right back.
Okay, thanks. Okay, you're counting time.
Yeah.
Okay, 2 minutes, we'll check the rhythm.
2 minutes over. Let's check the rhythm.
Okay, 2 rhythm check. It's still VF. Okay, shock again. Charging.
Okay.
Don't shock yet. Tell me when you're ready.
Yep, ready.
Ready, clear.
Stop, CPR.
Oxygen away, shock.
Okay.
Back on the chair.
It's still VF. Okay, CPR. Another 2 minutes, please. Make sure adrenaline's ready. Okay. Where's the anaesthetic team?
Yeah, we already called.
Okay.
Away.
Fantastic. Keep on with the CPR. Tell me if you got getting tired. Okay, we'll wait for the anaesthetic team to come in. Okay, are you ready?
Yep.
Okay, fantastic. Let me give you a handover. He's a 50-year-old guy. He's definitely got COVID, I think. He's got fever, he's got a cough, unfortunately, anterior infarct. We've taken the pictures. It's a blocked LAD. So can you intubate this patient?
Yes, we can intubate.
Okay, has it been 2 minutes?
2 minutes over.
Okay, check the rhythm. There's still VF shock, please. Okay, charging. Oxygen away. Shock.
Oxygen.
Okay, give the adrenaline. Okay, get the camera out of the way so they can intubate.
Adrenaline going in. 1 milligram adrenaline.
Okay, so 50. The other way. Okay, let's get the C-arm away. Keep on with the CPR. Adrenaline is in. Then will you get tired, Callum? Okay, can you angle it, please?
2 minutes over.
Okay, let's take the table downwards as well. Okay, give you some space. There you go. Okay.
Stop CPR.
Okay, stopping. Rhythm, still here. You got the wire balloon ready?
Yep.
Okay, fantastic. Okay, as soon as they're down, we'll get the camera back in.
Yeah.
Continue CPR.
Okay, CPR start. What's the timing?
Yes, 30 minutes. 2 minutes over.
Another 2 minutes to go on. Okay. We carry on CPR. We can't shock at the moment. Carry on CPR. Okay, are you happy for me to shock him again? Let's start. Tired first. Okay. Callum, tell me if you're tired. I'm good. Okay. You ready with another adrenaline?
Yeah.
Okay. Are you happy for us to shock him? Okay. Look at the rhythm. Okay. Shock.
Okay.
This should work. You get oxygen now. The oxygen saturation should be coming up. Okay. Clear. Okay. You've got some output. Okay. Fantastic. No more CPR. Get the camera back in. Okay. I'm going to wire it. Okay. So the wire's going through. Okay. Fine. The 2.5 balloon. Okay. We'll have that. Okay. So we've got the 2.5 balloon up. Inflate. Deflate.
Yep.
Okay, we've got flow. That looks like probably a 3 by 18 stent. Okay, let's try that. Okay, so 3 by 18 stent.
Alright, that's the
Yep.
96 there.
Okay, fantastic. Let's put that in position.
Yep.
Okay, let's inflate.
Inflating 12, 14,
14, 16.
16,
Stop, deflate.
deflated.
Okay, let's take a picture.
Picture.
That's good flow. Okay.
Yep.
Okay, that looks good. Okay, let's take the catheter out. Okay, so we'll seal the access. Okay, so from our point of view, the thing that's stable from the corollary point of view. Anaesthetic team, are you happy from your end?
Yeah.
Okay, and we contacted ITU. Okay, can we make a call to ITU? ITU need to know there's a COVID positive patient coming. Okay, so if you make sure that ITU is ready. Okay, fantastic.
Angela is calling.
Okay, we've got a tube patient. Okay, we've got a case finished. Okay, so rigid fine, that's good. Thank God we got away with that.
Yeah.
So they're going to go to ITU. Let's undo the drapes and get him onto the trolley.
Okay, so we've seen the anaesthetic team come in and help intubate and resuscitate the patient. And we've seen some cycles of CPR eventually ending up with a return of spontaneous circulation. So, Rasha, if you're the operator there, then how are you helping protect the anaesthetic colleagues?
Yeah, so one of the key things I think is that the anaesthetic team need to understand that they must be wearing leads from the very beginning of coming into the cath lab procedure. And actually very early on, a mistake was made where someone put all of their PPE on and forgot to put leads on and had to rush back out to sort that out. And what we've done around our cath lab is we have lots of photos so that they know how to don all the right equipment, including leads, and then obviously how to take it off at the end of the case.
Okay, and so what about the idea of knowing who everyone is behind the masks?
Once all of us had our PPE on, our masks on, our visors, sometimes goggles as well, it's incredibly hard to work out who anyone is. And our first sort of go at COVID patients was we decided we would all wear the same gown. So everyone was in the sterile gowns, albeit that many members of the team were not sterile and didn't have sterile gloves. And that made some confusion because occasionally you would try and hand sterile bits of kit to non-sterile members of staff. So we quickly learned we needed to understand who was sterile and who wasn't. And so what we decided, how we modified our PPE, was that the non-sterile members of the team actually wear an apron on the outside of their gown. Obviously, you could put a name on your gown, but then that would require sterile pens and the use of sterile pens. And obviously they're not reusable. So we've taken to trying to put names on visors just so that we know who everyone is. So you don't just try to look them in the eye and tell them what to do. You say their name and then you give their instruction, and then they report back that they've received that instruction back to you by your name. And that's kind of the best way that we have of making sure we know who everyone is and that they all know their roles.
Fantastic. David, you saw that a resuscitation, I presume, is fairly standard all across Europe, at least. Mm-hmm. And so the first 3 shocks count as 1 shock in our resuscitation protocol. Is that the same for Sweden?
Yes, we perform the same way there. And I would also say that we focus very much, maybe a little bit more on compressions in Sweden. So that is what we start with always. And we are always, I would say, in most cath labs in Sweden using a mechanical chest compression device. And that's something that we think is good for staff safety and for efficiency for the patients. We don't know in terms of COVID-19, of course, how this affects the virus transmission, but this is such a vital part of our standard procedures in the cath lab, and also a very good way that we could use the ABP. And also when the patient is intubated, the end-tidal carbon dioxide, to know how good the compressions are. And we find that very feasible to combine with the mechanical chest compression device.
Okay, there's 2 interesting points there, Dave. I could bring those out. So we've certainly toyed with both the Lucas device and the AutoPulse in our labs. Partly you sort of need to know they're about to arrest before you can get the device into position quickly. And then all of them interfere with our procedure. So I must say at Imperial, we don't routinely have the board for the auto pulse underneath the patient at the start, or indeed the chassis of the Lucas device. And our outcomes with both of those, it happens very rarely, is let's say limited. So David, you're telling me that someone who's in danger of a cardiac arrest, not in full cardiac arrest yet, because our patient is not in cardiac arrest until they get into the cath lab table, you would already have the board of the auto pulse underneath the cath lab table, would you? Or would you be putting that in after the arrest? What would happen?
So basically, when we have a very high-risk patient or that already crashed on the way into the hospital, we put the board on before we put the patient into the lab. Or we have a standard procedure that we have 2 dedicated persons who put the Lucas device or the autopulse device on a very sort of like step-by-step approach. And this actually has been possible due to simulation training, that we have trained so much that we know, the nurse know, the radiographers know, and the operators know what, for example, which angles should the tubing be in order to be able to put the chassis on the Lucas device.
No, that's excellent. I think it is absolutely right that the weight of the patient, you have to lift them up to get any of the boards underneath. That requires a lot of simulation training to get right. So that's a very good point. Probably a difference between Sweden and some of our practice in the UK, because it's not really caught hold as much in the UK. What about oxygen? And so the oxygen is on the patient and we're about to defibrillate. I'll ask 2 questions to you, David. Number 1, are the defibrillator pads automatically on during every primary angioplasty? And number 2, is Sweden focused on putting the oxygen off and on before the electricity is applied?
So in regards of the pads, if you ask me personally, I would always put them on. I think that's a great way to save time and causes, if you don't have it, it causes unnecessary stress and you disturb the procedure. So, but in real life, what we do, we don't have a standard sort of like guideline for how to put the pads on. But in my hospital, in all major anterior infarcts, or if they had an arrhythmia prior to arrival, we'll always put them on. In regards of the oxygen, that on and off have started to catch on a little bit, but not as I hear from you in the UK, where you have this as a standard procedure.
Okay, Rasha, the quality of the CPR, how do you assess the quality of CPR during your arrest?
Well, I think that's one of the easiest thing in the cath lab, as opposed to when you have an arrest on the ward. You have invasive pressure measurements at all times, so you can actually see the pressure that's being generated from every one of those compressions. And so there are times when we know that certain people are fantastic at CPR and they generate fantastic pressures, and then others not so good, and you might take them off the chest earlier and rotate with someone else. You can also see when the person who's doing the compressions is tiring, and you can feed back to them. And I think the other key part of all of this, obviously, is that we often see with simulation training that often our fellows will say things like, everyone stop, we need to check the pulse. And actually, you don't need to do that in a cath lab. You have invasive pressure measurements. So in fact, all you need to do is stop and look up at the machine, and you can set the readings, and you can see exactly what's going on in terms of whether that person now has output and what's going on, obviously, with their ECG as well.
I think the other thing that I would say is that if we have a catheter in the left main stem, for example, without wires in yet, then normally I've removed that catheter so that the CPR doesn't cause damage. But alternatively, if in fact we already have wires down, then I think the catheter is safer. And all you have to do is, I think, hold your hands over the patient's body without touching them. So as soon as they jump, you can put them back down again, because otherwise, especially if you're doing radial, you found that everything's come out of the body, including the sheath. So I think that's a key learning point to bring out, which this mannequin, the one thing it doesn't do is jump. So you can apply electricity to this mannequin, you can defibrillate it, you can see the pressures, but the mannequin does not jump in the same way as a human body does when it's electrified. And so I think a learning point to bring out, in addition to this simulation, is to have your hands hovering over your puncture point to grab the equipment as it starts to fly, because you will not be electrocuted after that second where the electricity is delivered, but you may save your procedure and a lot of hassle if the sheaths still are in the body. In terms of the procedure itself, we've seen a single vessel angioplasty. Rasha, what if there was another vessel to treat? What would you do in the midst of this COVID crisis?
It seems that doing complete revascularization relatively soon after the target revasc is important. So that might be at the same procedure, that might be within the same inpatient setting, but trying to get them home with everything having been done seems to have much better outcomes for our patients. The tricky aspect of this in the COVID crisis is which one is best. We don't know whether it's better to spend longer in the lab trying to make sure that we absolutely do as much as possible for these patients, knowing that they may not come back to us and there may not be another opportunity for them to come back, and therefore we need to get them as stable as possible before then transferring them to the intensive care unit or wherever they're going to go next. Versus, on the flip side, the argument being that for the team's sake, we should get in and get out, do the target, do as much as we can to open up that occluded vessel, and then think about the rest later if that patient survives and does okay from the point of view of their cardiac status, but also from their respiratory and kind of COVID disease status.
David, if I could come to you and say, documentation during all of this is quite challenging. Sweden, I suspect, is more advanced than the UK in terms of electronic databases, but they still need to be filled in. You saw the communication in and out of the cath lab with our video link. What's happening in Sweden?
So I actually was very impressed by the video here and the comlink, because I think that this is a good example of sort of adapting to a new set of working. We haven't been able to do that in full manners in Sweden. We have it actually in the wards, in the infectious disease wards, in the ITU wards and the CICU. And let me also make a point that I think that documentation is the result of good communication. I think Rasha put it out beautifully before with the closed loop communications, because if we have this sort of like, David, could you fetch this catheter? Yes, Rasha, I will fetch it. Here is the catheter. And it's very easy for the nurse or radiographer behind the screen that are doing documentations to put it in properly. We will have the possibility of not video communication, but audio communication. We have always had that. And we have sort of like a runner outside the lab that could fetch and provide it in a quite safe manner.
Okay, Rasha, can I ask you, obviously we as Imperial have a large pressure wire program, a lot of research with IFR. We've also got a very high rate of intravascular imaging, and certainly the fellows have a standing order that if I turn up on their cath lab table and they put a stent into me and they haven't done an intravascular ultrasound, for example, then I will haunt them. So they know that full well. But in the midst of the COVID crisis, we can't have all of our toys. So what's the essential toy add-on beyond just a balloon and stent that you would want in your COVID cath lab?
We really still need to do best practice PCI. We have one shot with a lot of these patients and we need to get it right. And if they are particularly thrombotic, the last thing you want to do is have underexpanded or malapose stent in this very highly thrombotic, very sick patient. You're highly likely to have complications acutely. So for me, as best practice, what I need in that lab is intravascular imaging. And for us, we have an integrated IVUS system within the lab that we have designated our COVID lab. And for that, we use the solid state Eagle Eye Phillips catheter. So I've elected on balance that I get good outcomes if I image with and have stuck to just using the solid state catheter for these cases.
Yeah, can you put the key now? Because I'm holding them. Just okay the area, go back, please. Thank you. Thank you. Stay there, please, sir. Thank you.
Ladies and gentlemen, we are about to have a COVID positive patient be transferred through our corridor. In a minute, I'd like you to follow me so we can then vacate the area for them, and then we will bring you back once the area is cleared.
Hello, sir. Clear the area, please. Stay there, please, sir. Clear the area, please. Move. Can you move, please? Move. Are you ready now? Yeah, I'll send you when you go upstairs. I'm here. Yes, that is. Yeah, keep that. Keep that. Okay, we're moving. Yeah, go, go, go. This is the ICU.
So the patient has thankfully recovered from the cardiac arrest and survived the primary angioplasty done by Iqbal Malik. So the question then is, how do we arrange the decamp to the intensive care unit? Very occasionally, anaesthetists have suggested that they extubate the patient in the cath lab. I'm very rarely agreeing to that scenario because they're still in a very acute phase. So have you come across that, Rasha?
Yeah, certainly. I think for me, I would like a period of stability before they extubate the patient. So our patients have remained intubated, have then gone off onto intensive care, and there they've decided about extubation. Now, obviously, as you've done a long, hot procedure, everyone's a bit tired and a bit fraught towards the end. And so the last thing you want to do then is spend another 45 minutes or an hour waiting in a cath lab for an ITU bed and the ability to move this patient. So we've kind of instigated that ITU bed very early, essentially when the patient enters the lab.
How do you get the patient from your cath lab to your intensive care unit, given that even Sweden does not have a teleportation system as yet?
We don't deliver the patients to the ITU. They come and fetch them from the cath lab. Nevertheless, it's very important with the external barriers of the corridors. You have to have guards, so to speak, to be able to do this transfer. Because if they're in a ventilator, we consider them obviously high risk for transmission. So this is very, very important for us to have in a timely manner, to be able to allocate the right resources. And I would say also that some lessons learned from different parts of the world in the COVID-19 is that if you get the infection, the transmission deep into the hospitals, you are in big trouble.
How do you safely remove PPE?
Yeah, so that's, I think, actually the moment at which we're at greatest risk, particularly after a long procedure. You're tired, you're hot, you're sweaty, you're desperate to take all of this kit off as quickly as possible and be able to breathe properly again. we have to remove the PPE within the cath lab once the patient's obviously exited. We have a series of pictures all over our cath lab trying to teach people how to doff or take off their PPE correctly to make sure that they do it. So the operator will have with them a nurse or someone who's going to help. The first thing that happens is that the nurse will undo the back of my gown, and then I will remove the gown and the first layer of gloves as one unit, basically. All of that gets disposed of within the cath lab, so it doesn't come outside. And then for us, if it was a COVID suspected or COVID definite patient, I'll have a second layer on. And then at that point, I'll remove the second layer of gown and gloves. And then what we usually do then is we put another pair of gloves on to then remove the visor, the goggles, and then obviously, you know, the hood and the mask. We've got these wellies that we also wash and take off before we come outside. And then we will come out of the cath lab area into our scrub area, essentially with everything having been removed.
Can I say, ask David then again, how do you think we should communicate with the family to update them?
We have thought a lot about this, and fortunately for my part of the country, we haven't had that kind of exponential ITU patients. So what we have been managing to do is that every day we have a psychologist and a social worker on call that are calling to the family at home, telling them what has been happening, and also establish a connection. I think that's sort of like establishing a relationship between the hospital and the relatives. And this is actually something that we will, in some manner, try to keep on after the COVID-19 pandemic, because the results are so good here. For the main COVID-19 patients that are not in the ITU bed, we can certainly not call everybody, but we will have a COVID-19 hotline that are manned day hours.
I think the other thing that we've discovered is that we acquired some iPads and some FaceTime contact in two varieties. I also saw on social media that was happening. Two varieties. Number one, the good news that the patient can now talk to their relatives and there's improvement. And unfortunately, also, a very moving account was on social media of a FaceTime of a very large family saying goodbye to their patient and their relatives because they were not going to make it. And I mean, that's an amazing use of video technology, and my heart really goes out to the doctors and nurses that actually set up that link, because it must have been a very emotional time for them just watching the family say goodbye as well. So I think these technologies are really useful, and I think some of those are really here to stay. We've seen the whole of a simulation scenario with a COVID positive patient who had a primary angioplasty and a cardiac arrest. We could have made the scenario more complicated, but there are so many learning points already to bring out. And I think there is quite a number that we have learned and actually implemented in our regular practice. So for example, the video calls are now becoming a much more routine thing and are much more practiced, and people are used to the way to switch it on and switch it off. Staying calm in the crisis comes from practice. You have to train yourself to be a bit calmer and not shout at other people who are trying to do their best, especially with the masks on, because they can't hear you. But probably the most important part of any simulation is the debrief at the end to bring out and consolidate the learning points. And I think there's one other point to bring out, and that is when the anesthetic team comes in, a brief pause, not of the CPR obviously, but a brief pause of what the cardiology team is doing to update the anesthetic team and perhaps even learn their names, produces a completely different team dynamic, which I think Rasha and I, we've certainly found that once we actually learn the name of the anaesthetist, they become really good friends and not the other that has come into the room. With that, I'd like to thank Rasha and David for joining us and for our audience who's been watching. Thank you for being interactive, and hopefully we've answered your questions. Part of the COVID-19 Spotlight response has been a whole set of videos that we've produced to try and help you in each stage of the process. And there are many more videos obviously out there. I hope we all survive this crisis.